A very good morning and warm welcome to one and all present here. I, Dr. Sonam Batra, and I, Dr. Anjali Nandavar, today on behalf of Department of Orthodontics and Dentofacial Orthopedics, Swargya Dada Saheb Karnik, Shruti Dental College and Hospital, extend a warm welcome to Honorable President Sir Shri Sharatji Karnik, Sir, Honorable Secretary Shri Hemanji Karnik, Sir, Requested Dean Dr. P. Mahesh, Sir, today's distinguished speakers, Professor and Head of the Department of Orthodontics and Dentofacial Orthopedics, Dr. Rashmi Javrekar Ma'am, all the respected HODs, teaching faculty, all postgraduate students, and all the attendees who have joined online and offline for their gracious presence. We thank you each and every one of you for accepting the invitation of today's program.
The auspiciousness of this ceremony is incomplete without the blessings of the Almighty, the one true power residing above us. Let us all share this auspicious moment by lighting the traditional lamps. The moderation of today's session will The moderation of today's session will be done by Dr. Rashmi Zavekar ma'am, and the questions will be asked in the last 30 minutes of the session.
Orthodontics is a dynamic field and has proven itself to be much more than a cosmetic field of dentistry. The field of orthodontics is at the pinnacle of its progress at the moment, with newer concepts, technique, and appliances being introduced with each passing day. Dentistry is a branch not only associated with teeth but also includes other aspects of craniofacial complex, including the TMG and other supporting structures.
Cleft lip and palate is considered to be one of the most common birth defects involving craniofacial structure. This anomaly not only has its aesthetic consequences but also affects certain necessary functions such as feeding, nasal breathing, and phonation. All of these aspects are addressed as a part of an integral treatment. The most significant advances in treatment of cleft lip and palate happen with the development of a multidisciplinary team that approach the defect jointly and in a coordinated manner to obtain good results. This interaction has enabled the comprehensive management of this condition with excellent results. Now I request Dr. Rashmi Davekar ma'am, Head of the Department of Orthodontics and Endofacial Orthopedics, to welcome the guest speaker and address the session with an introductory speech.
Warm welcome to one and all.
A warm welcome to you all. Welcome, Dr. Puneet Batra. Long time heard you. Without wasting the time, as already we have lost some time due to technical difficulty, and keeping pace with the time, I request you, Dr. Puneet Batra, to start your session. Welcome one and all. Welcome all the delegates. Welcome Dr. Puneet Batra. Welcome Dr. Ashish. Welcome Dr. ASHITH. Waiting to hear from you all. Dr. Puneet, you can start, take over the mic now.
Says dinner on yes, Palate. The day one meeting hasn't started. You have to join when it starts.
सर एक बार रिफ्रेश करिए ना
Welcome, Dr. Ashish. Audio needs attention. We can see you, but you are not heard.
सर यू आर नॉट ऑडिबल
Yeah, am I audible now?
Yes, sir.
Uh, share. Can I share my screen? Or
Can you share it? So we have just started. You can start now. You can share your screen too.
right. So, can you see or not?
नॉट नाउ सर
No?
इकडेच बसा ना तुम्ही आज बेटर.
Can you see the screen? No.
नो तुमचा स्पीकर बंद करा
ते कुठे दिसतं? हां.
हेलो
Yeah.
सर फोर्थ ऑप्शन इज शेयर स्क्रीन
Yeah. I'm just trying to do that. It's taking a lot of time. I'm just checking that.
सर एक्चुअली आफ्टर क्लिकिंग ऑन शेयर स्क्रीन you select the second option windows हाँ just now it's
Yeah.
visible
Yeah, the screen is visible?
Yes.
Yeah, right. So can I start, or is there?
Yes, sir. You can start now.
Right. So
Sir, let us introduce you, sir. Untitled.
A very good morning to one and all. It's a great pleasure for me to introduce you, sir, as our guest speaker for today's scientific session. Dr. Puneet Batra, sir, is an M.D.S in orthodontics from prestigious AIMS, New Delhi. He is the professor and director, PG Board of Studies in Mano Rachna Dental College, Faridabad, Haryana. He is presently the editor of Journal of Indian Orthodontic Society in the year 2018 and to 2023. He is the Cleft orthodontist at Global Hospital and Research Center, Mount Abu, Rajasthan, and St. Pramanan Hospital, New Delhi. He is the recipient of P.P. Jacob Award as well as the G. Kannappan Award by the Indian Orthodontic Society. He has been awarded the prestigious Commonwealth Scholarship at Great Ormond City Hospital for Sick Children, London, as well as the T.C. White Award in the Dundee Dental School, Scotland. He is a M.Orth from Royal College of Surgeons in Edinburgh and an FFD.Ortho from Royal College of Surgeons in Ireland. He is a diplomat of Indian Board of Orthodontics, DNB in Orthodontics, and has done PG Diploma in Hospital Management, PG Diploma in Invited Speaker. He is the past president of Indian Society of Cleft Lip and Palate and Craniofacial Anomalies in the year 2019 and 20. He has been nominated to Dental Council of India at Government of India in July 2019. He has been awarded fellowship by 3 Royal Colleges, namely Royal College of Edinburgh, Glasgow, and England. He is a member of Smile Trend India Advisory Council as well as Smile Trend Research Innovation Advisory Council. He has been recently certified by DRDO in Artificial Intelligence and Machine Learning. We are privileged to have you with us today, sir, and we request you to begin with scientific session of the day. Over to you, sir.
thank you very much for this kind introduction. At the onset, I'd like to thank Rashmi Madam for this opportunity. She has been, one of the people well knit with me since the time we first met at Vartha during the postgraduate certificate in cleft orthodontic course. Thank you very much, ma'am, for this opportunity. So I will begin my talk, which is basically cleft orthodontics an overview. I would be discussing about how you can become a team member in cleft care. So, as a person working in cleft care since the last 20 years, I would say that when such patients come to us, we realize that as orthodontists, we are not, we are the smile architects and we can bring about big change. But what do we do in such scenarios? It becomes very difficult for us to decide what treatment protocol to follow because the textbooks written in cleft are basically talking about ideal case scenarios. It's very difficult to get ideal case scenario. So let's look at how a team would bring about an ideal change for these patients. Well, uh, this is from the American Journal of Orthodontics, from one of the units in America, which talks about how their team developed for treatment of craniofacial anomalies. So you realize that as a team player, orthodontists per se are one part of this huge gamut of team which is going to deliver cleft care. So, the basic principle of cleft care involves that we as specialists need to understand that when we work in a team, there are some ethics and principles of working in teams. The best outcome for the patient is critical. It's not just the teeth which we are treating the individual. So, when a cleft child is born, the first procedure done is lip repair. We look at the birth weight of the child, we look at the hemoglobin, and so this is an outcome of the primary lip repair. So you look at the outcome and you can see that these patients don't look like as if they had cleft ever. Basically, the primary surgery means the first surgery, has an impact on orthodontics as well as the total rehabilitation of the child. Therefore, a good primary outcome is very, very important if good primary surgery is done. So now you can look at these bilateral children, and these children have been operated in a center in India. So, good outcomes can come if good surgical teams work together in delivering cleft care. Now, another adult patient, where so you can see the change in this lady. You know, she wants to dress up, she wants to make up because there has been a drastic change in the facial outcome of this patient. So the second surgery which happens is the repair of the palate, because all of us need to speak, to coordinate with our colleagues, we need to swallow, and also the normal growth of the maxilla depends on the palatal growth. So, you know, you can see pre and post lip palate repair, that a complete palate has been repaired. So what is the gold standard of cleft care in the world? You know, when you look at literature, the best protocol or the best outcomes have been found to be in Norway, where the Oslo protocol is followed. So what is this protocol, and does it apply to all centers in the world? No. You must be aware that there are more than 700 protocols for cleft care in the world. They repair the lip at 3 months using the Millard technique. In bilaterals, using the straight line technique, one side is repaired at 3 months and the other after 4 to 6 weeks. The palate is done at 18 months. Why do you do the palate at 18 months? Any time before 2 years is a good time for palate repair. Why? Because the child speaks the first few words by the time they are 2 years. No, cleft orthodontics has become a specialized branch. What happened in the year 1992 was a chain of articles by a group of researchers in Europe who looked at outcomes in Manchester, Copenhagen, Amsterdam, Oslo, Stockholm, and London to see what would be the right protocol for bringing about good outcomes. So these centers did not tell which was which center. They labeled it as A, B, C, D, E, and F and looked at the different ways they treat the cleft children. So all of them had a different protocol. You know, palate surgery was done at a different time using a different technique, lip was done at a different time, bone grafting was done, and pre-surgical infant orthopedics was done in some centers, in some it was not done. Also, we know that in a non-cleft versus a cleft child, what happens as the child grows, the maxillary growth it stays behind the mandibular growth. Therefore, you know, there were some lessons these master articles from Eurocleft taught us. And what were these lessons? The lesson was that primary bone grafting is not useful, meaning it's the growth of the maxilla. Pre-surgical infant orthopedics is a controversial topic. Feeding plates are not useful. You know, many centers still give feeding plates, but there is no scientific rationale for a feeding plate. Primary surgery is critical, and the first surgery, like I showed you, good outcomes in the lip and the palate, and the balance between growth and needs to be also your maxilla needs to grow well. So what happened after Euro outcome was very simple. Do good primary surgery. So how does it affect orthodontics? It affects orthodontics in this chain of events. See, this is the full gamut of procedures an orthodontist can be involved in cleft care. The first one is pre-surgical infant orthopedics. When the child is born, till the time of the lip repair is a time when cleft orthodontics work. Then you see this red box. This is the golden era for cleft work. There are two boxes here, one which says expansion, the other which says bone grafting. Followed by, you know, when the growth ceases, to do orthognathic surgery if indicated, and also till adulthood, look through the child and bring him to integrate with society. So cleft orthodontics has a big role to play in cleft treatment. So, you know, there is no textbook which will tell you how to treat every child, because every child is different. Look at this picture. If you were to place the bracket in the correct position, what would happen? The root would come into an area where there is no bone. Therefore, the bracket is angulated. So, you know, you have to work differently, understanding the concept rather than following a cookbook approach. So let's take every step at a time. So this is a child who's born as an infant, and he is there with us till the mixed dentition. So like I said, feeding plates have no role. When you look at literature, you find that feeding plates for interventions for infants with cleft palate have no role at all. This is as early as 2004. Now, pre-surgical infant orthopedics, PSIO or PNAM, there are different names given to this procedure. What is this procedure? Now, this procedure is basically exploiting the natural scenario. Estrogens are very high during the first days of life. Therefore, the tissue is elastic. So, the nose and the lip are plastic in nature because intercellular material is disconnected. Therefore, you can bring about any change. You all would have played with plasticine. You can shape the nose as well as the lip into any shape you want. So if you were to streamline the three objectives of NAM, first is to reduce the severity of the defect. Second is to eliminate surgical columella reconstruction. I will show you in a picture in a while, and improve the surgical outcomes. So there are different types of appliances which have been used in literature. There are active appliances which apply active force. Now, active force is not indicated. Why? Because it restricts the growth of the maxilla and makes the patient go into a class 3 kind of situation. The other thing is passive plates, whether using extraoral strapping or without extraoral strapping. The most famous of these is the Grayson appliance. This is the Grayson technique. There is a plate, and if you look at the second picture from on the extreme left, there is a plate with a wire component going into the nose and elevating the alar cartilage, the nasal cartilage. Therefore, this swan's neck kind of shape of the wire is actually pushing the nostril up and uprighting the nostril. If you look at the plate on the extreme right side, there is a small hole which is 6 millimeter wide, because if the plate comes down, the air. So you have a situation of unilateral or a bilateral where these appliances work. Now, you can do adjustments of the appliances by addition and subtraction of soft reliners on the side where you want the molding to happen. Now let's look at a clinical scenario. This is a bilateral child with a premaxilla which is hanging out. So we've given him a modified Grayson appliance. What has happened? This is pre-treatment. This is post-treatment. You see the premaxilla which was hanging out has come inside and the arch form has been established. And this is the superimposition of the pre and post outcomes. Therefore, we've managed to get a good clinical outcome. Look at this bilateral child. The premaxilla is, twisted and shifted to one side. Now, what can you do to achieve a midline symmetry? Have a look here. This is the premaxilla. You twist it to one side, and you can see a neonatal tooth on the right side. And this is what happens post. So, this has medialized the premaxilla, but observe one more thing. Look at the pre. There is no columella visible. There is no columella tissue. But look at the post. You can see a columella. Therefore, nasoalveolar molding actually makes life simple for the surgeon and also improves the outcome. Look at the role of nasoalveolar molding in a unilateral kit. Now, this is pre and post, and you can see that the arch form from pre has become a very good arch form in the post. So, it has limited role in unilateral, but again, it can be used in indicated cases. Now, there are some cases where it's difficult to make an impression, patients with cardiac anomalies or other issues. So, look at this child. We've given him a nasal elevator only. There is no plate which is given. This elevator is called Cleft. This is an elevator, and there is a tape which tapes the lip.
Hello.
For
No,
example,
unmuted.
in this patient, there is no vestibule. So you will need to do a vestibular depth, vestibular deepening procedure or a sulcus deepening procedure before the bone graft can be done. So this is a bilateral patient. If you look at the outcome, there are small teeth, but the maxilla is one continuous unit. And if you saw the sequence of development, if you look at the cephalogram, the incisors are retroclined in a very big way. Therefore, to get an optimal outcome in bilaterals is very important to stabilize the premaxilla. So, I would say that it's very important that we do the bone graft procedure very well. So, if you see pre and post, this is the change you have brought about. And here, pre and post, so this is the change you have brought about. Now, this is about, preparation for bone graft. Another thing you can do is protraction of maxilla. So, do you protract in all cases or you don't? The master article on this was given by Rolf Tindlin. He says that, when you use protraction in unilateral cleft children, the skeletal advancement is 45%. But in bilaterals, it is only 10%. So be careful. Many times we look at the reverse overjet of -2, -3 millimeter, -4 millimeter, and we want to protract. But does it actually have a positive effect or it will have no effect? So this is a child. We've given a petit type of face mask. This is pre-treatment. There is a reverse overjet and we've given a splint, RME, and we have protracted the maxilla. Now, what happens many times is that we are unable to protract the maxilla. We haven't protracted the maxilla and the child has become an adult patient. Now, can we still do protraction? We can. There is something called as Ultramic. What is Ultramic? Eric Liu gave a protocol of alternate rapid expansion and constriction. When you expand and constrict the maxilla breaks from the sutures and becomes mobile. So you can protract it forward without doing any surgery. But you cannot use the RME screw. You will have to use these two V-shaped expansion screws. You will have to create an appliance. As you can see in the picture, we've used two V-shaped expansion screws. We have created a single appliance. We have loosened the maxilla. So I'll show you a case. This girl has a maxilla which is retrographic, a mandible which is protracted. We want to protract the maxilla forward. You can look at the teeth, they are lying so far behind. So this is the maxilla. We want to protract in this case. So this is protraction done with Ultramic. And after protraction, after Ultramic, we've used a face mask. We've brought this maxilla forward and you can see a positive overjet has brought about without surgery. The patient is not interested in surgery. We do not want to protract the maxilla. So you can have a look at the improvement in the profile using Ultramic if surgery is not an option. So this is how we treat a patient in the mixed dentition. So, for the permanent dentition. So I would just, revise and say that, when a child comes for you for comprehensive care in Cleft, first thing is to see whether you can deliver pre-surgical infant orthopedic care. During pre-surgical infant orthopedic, it is very important that you are trained in basic life support because these small kids, how you do basic life support is different from how you do it in an adult. Second thing is you can pre-surgical infant orthopedics. That is that maternal estrogen levels are very high in the nasal septum of this child and they remain high only till 4 to 5 months of birth. So nasoalveolar molding or any procedure for PSIO should be done in the first 4 to 5 months only. The next phase is the child growing up and you need to take care of oral health because when you will do a bone graft, if the cleanliness periodontal status is poor, it is likely to lead to bone graft failure. So in the mixed dentition, the timing of the bone graft is very critical. Therefore, good radiographic evaluation, good follow-up of these patients is very important. So when like to use NITA expanders, most parts of Europe they use a quad helix. You can use any appliance, you can even use an expansion plate. It is going to create a expansion in the maxilla. Another thing is protraction.
You are now muted.
तो कोई बात नहीं, आप नेक्स्ट स्पीकर का कंटिन्यू कर लो. Yeah, ma'am. Thank you, ma'am.
You are now muted.
Yeah, am I audible now?
You are now unmuted.
I didn't get you. Yeah, is it full screen now? Yeah. Can I start? Yeah. Very good morning, one and all. Sorry for the technical delay. So at the onset, I would like to thank Swargya Dada Saheb Dental College and Hospital for giving me this opportunity, especially to Punit sir and Rashmi madam for inviting. Today, my topic of presentation is pre-surgical nasoalveolar molding, modification, and complications which are related to pre-surgical nasoalveolar molding.
Dr. Ashit, can you just give me 5 minutes? I'd like to introduce you first.
Yeah.
Dr. Ashit, can you hear? Please give me 5 minutes to introduce you to my new delegates.
Yes.
Now we'll move on to the next part of today's session. I would like to request Dr. Rana to welcome our next speaker, Dr. Ashith sir.
You are now muted.
A very good morning and a warm welcome to everyone present here. Myself, Dr. Rana Chikle, second year postgraduate student from Swargya Dada Saheb Karmek Smriti Dental College and Hospital. Take this privilege to introduce Dr. Ashith sir. Um, Uh, he he has pursued his graduation from AJ Institute of Dental Sciences and M.D.S from Krug Institute of Dental Sciences, Virajpet, Karnataka. He has also done certified fellowship program in cleft and craniofacial orthodontics by Smile Train organization at Sharad Pawar Dental College and Hospital, Varda, and certified training in Tweed Merrifield Edgewise Mechanics under the Korean Orthodontic Research in 2015, and he is currently working as associate professor at Department of Orthodontics, Manipal College of Dental Sciences, Mangalore, and he is also course faculty for the University of Minnesota and KUMS Partnership for Development of Health Educators in Afghanistan and consultant orthodontist. He has many achievements in his name, including 2 national awards for clinical innovations in pre-surgical nasoalveolar molding and also Best Innovation Award by Manipal University Technology Business Incubator for his active appliance design in nasoalveolar molding in bilateral clefts, and also won the table clinic in iOS conference in Kochi 2018, and also best innovative paper in 2019 iOS conference Bhubaneswar, and co-speaker in the field of cleft and cleft lip and palate, orthodontic surgery and orthodontic management with invited guest speaker and paper presentations at both national and international conferences. Uh, it's our pleasure to have him as our guest speaker today, and I request you, sir, to kindly take over the charge.
Welcome, Dr. Ashit. Eagerly waiting to listen to your new innovations. You can start.
Thank you. Yeah, at the onset, I would like to thank Swargya Dada Saheb Dental College and Hospital, Nagpur, for giving me this opportunity. I would also like to thank Dr. Punit sir and Rashmi madam for inviting me. Today I'm going to speak on pre-surgical nasoalveolar molding, modifications and complications associated with nasoalveolar molding. I would be covering what modifications we have done at our center and also what complication we routinely face when we treat such patients. So, as you all know, that pre-surgical nasoalveolar molding, it was Matsu who found out that the cartilaginous molding was possible. So from there, this whole process of nasoalveolar molding started, and he was the first to incorporate a spring into spring of a silicon rubber, and showed people that molding can be done. Then over the years, it was Grayson who adapted his own nasal stent into the obturating plate and then named it as nasoalveolar molding. So from where this term called as pre-surgical nasoalveolar molding is used after that. So it is almost about like 40 years of neonatal maxillary orthopedic. The treatment started to drift away from the traditional aims and technique with the introduction of nasoalveolar molding in 1993 by Barry Grayson. So what was the rationale behind? The high level of estrogen at the time of birth, which correlates with the increasing hyaluronic acid, which inhibits the linkage of cartilage intercellular matrix, which increases the plasticity of the tissue cartilage, which will help in molding uh, of the alveolus and the nasal cartilage. What are the claim benefit of nasoalveolar molding? So we need to get a well-aligned arch prior to primary lip repair. Then by reducing the cleft defect, it also reduces the tension of the soft tissue during the surgical repair. The number of surgical revisions required is less, improves feeding. It stimulates growth and development of the palatal segment, improves nasal symmetry and elongation of the columella, and correction of the nasal cartilage. So it also normalizes the tongue position, thus resulting in better speech. There is a positive psychological effect on the parents because parents can also participate in the treatment process. Results are stable, and it also reduces the overall cost of the therapy. So NAM appliance, there are different types of NAM appliance you see in the this thing. So you mostly we divided it into two types. That is, one is active as well as passive. So I will try to show you few cases on both the type of nasoalveolar molding appliance. When do we call it as a passive molding? A customized plate, a molding plate of acrylic is used gently to direct the growth. Here we don't put any active forces. We are just directing the alveolar segment to a desired position. And active is when we do modifications by adding or relieving. That's what is followed in Grayson's technique. So what is the procedure? Initially, we take a primary impression onto which the primary cast is poured. This is how it is done. Onto that primary cast, we do a special tray with the stoppers in place. Yeah, ma'am.
Convenience, but I request you to start from beginning.
Yes. Yeah, this is where I belong to. I am an associate professor in the Department of Orthodontics, Manipal College of Dental Science, Mangalore. So at the onset, I would
You are
like
now
to
muted.
thank organizer Rashmi Madam and Puneet sir for giving me this opportunity. So my topic of presentation is pre-surgical nasoalveolar molding, modification and complication. I would be covering few of our experiences with the nasoalveolar molding. So it all started here, the uh, nasoalveolar molding process by Metso. He was the first one who introduced a spring onto the silicone rubber and showed people that nasoalveolar molding possible. And then Grayson adapted this nasal stent to extend from the anterior flange of the intraoral molding plate and which is intact to the nasal floor, and named this technique as nasoalveolar molding. After nearly about 40 years of neonatal maxillary orthopedic, the treatment started to drift away from the traditional aims and techniques with the introduction of nasoalveolar molding in 1993 by Grayson. So what usually happens, the high level of estrogen at the time of birth correlates with the increased hyaluronic acid, which inhibits the linkage of cartilage into cellular matrix, increases plasticity of the tissue and cartilage, thus helps in molding possible. So the well-aligned tissue prior to primary lip and nose repair and more predictable outcome with minimal tension of soft tissue during surgical repair. The number of surgical revisions required is less. It improves feeding. It stimulates growth and development of the palatal segment. It improves the nasal symmetry, thus elongation of the columella and correction of the nasal cartilage. The normalization of the tongue position results in better speech and positive psychological effects on parents, because parents are also contributing for the treatment of the child. The results achieved are more stable, and there is always a reduction in the overall cost. So NAM appliance today I'll be covering it like on different sections like active versus passive NAM. The passive molding is a custom-made molding plate of acrylic which is used to gently direct the growth of the alveolus to get a desired result. While an active molding are made, there are some modification which you made in the internal surface of the molding plate by adding or by deletion of material in certain areas to get a desired shape. So what do we do? We usually take a primary impression onto which a wax spacer is made, stoppers are made, and a special trays are made. So this is what is an active appliance, where you mark the loading and the relieving area. The loading area is marked in black, and the relieving area where a red wax is added for relieving. So what when happens here? The alveolar segment, greater segment is pushed inwards and the lesser segment is usually pushed outward to get a symmetric arch form. So then once that is done, a molding plate is fabricated, and this is how it will look after adding of soft liner. And then the plate is inserted. Once you get an approximation of about 5 millimeter, the stent is added in Grayson's technique. So pre and 3 months post result, lip changes, alveolar changes, and you can see the alveolar changes pre, post surgery, and after 3 months. So once we started doing this, we thought we need to do few modification based on our patient's need. So as they say, necessity is the mother of all invention. We have then remodified Figaro's technique into a single stage nasoalveolar molding technique, which is a passive technique. So what we do here is we add a nasal stent immediately on the first appointment. And the nasal stent which are made with the TMA wire. So that's the modification we have done. So we wanted to reduce time of appliance fabrication also. So primary impressions, we take it using a wax, and that wax itself we convert it into wax spacer for secondary impression. So that's how we save some time. Once we get the primary impression, then we do something like a pre-predictive arch form. We predict what should be the final arch form which we need by adding wax. Once that is done, that nasoalveolar molding plate is fabricated with the incorporation of the nasal stent. A beta titanium wire is incorporated into the molding plate. So once molding plate is done, customized marking is done to fabrication of the stent. Soft liner stents are adapted and adjusted according to the alar length. So we also give a small loop below the nasal stent for the adjustment of the height. So this is the first case which we have treated, where we came at 6 months old. This is pre-treatment pictures. It's a unilateral cleft lip and the palate. You can see the cleft defect, collapsed nostrils. And after 2.5 months, this is what we could achieve. And at about 3 to 4 months, this is what we could achieve. That is the mid-treatment and before surgery. The nasal and the alveolar change. If you see intraorally, the alveolar defect has reduced from 11 millimeters to 4 millimeters. And this is the second case. This we have started at the age of like 9 days. And you can see unilateral cleft lip of the right side with the severely collapsed nostril. And this is what we could achieve in 1.5 months. So we usually see the patient once in 6 weeks, and we don't see it very often, like once in 15 days, because we use a TMA wire, and the activation in the TMA, it has a long duration of action, long range of action. So that's why we could wait for almost 6 weeks. This molding is also happening simultaneously. You can see the reduction in the cleft defect. That is the pre-treatment, mid-treatment, and the post-treatment result. The cleft defect reduced from 14 millimeters to almost 2.5 millimeter, giving a symmetric arch form. So that is the post-surgery result. That is at 4.5 months. This is the third case. We got this patient a little later. That is almost at 55 days. So as a lot of articles by Metsu says that you need to do the molding as soon as possible, because within first 6 weeks, and the high level of, because the maternal estrogen is what is very much important for the molding. But we got the patient little late, but we still continued with the nasoalveolar molding. This is how the appliance is placed. This is at 63 days, 84 days, and that's how we could achieve the nasal as well as the alveolar molding. So we thought, because we have started it late, so there would be some, the tendency of relapse would be much higher. So this is how the alveolar changes would be there, 11 mm, which is reduced to 1.5 millimeter. And then we have given some to hold the nasal changes. These are like silicone tubes which are used to maintain the nasal symmetry also. This is after surgery, about a month after surgery. That is the amount of change pre surgery and post surgery. So what we have done here, one what all modifications we have done. One is impression. We have used the wax as a primary impression. Then we have used nasal molding on the first day only, and also TMA wires have been used to reduce the frequency of visit. So we have used beta titanium. Why beta titanium? Because beta titanium has a very low modulus of elasticity, greater springiness, good corrosion resistance. So that is why it also has increased range of action, thus reducing the frequency of action. That's how we are able to reduce the frequency of visit to all our patients. So we went on to do a comparative study with Puneet sir. That is the effective of nasal molding therapy using two different techniques. One is Grayson's technique, and one is our single stage nasal molding technique. And this is how we have done a 3D model superimposition. And what we found out is alveolar molding is patients with unilateral cleft lip palate with Grayson's as well as the single stage technique. Both were equally effective. But an added advantage in our technique is the frequency of visits is being reduced from 15 days to we see the patient once in 6 weeks. That was the advantage. So bilateral, we usually use an active nasoalveolar technique, and we have designed an appliance called as a 3D Versa screw. So in this 3D Versa screw, the objective of treating a bilateral cleft is to retraction of the premaxillary segment, centering of the premaxilla, approximation of the lip segment, and to actively mold the nasal cartilage. So you can see the appliance design. A 3D screw is incorporated. For the anterior posterior movement, it is incorporated in an open mode, and posterior it is in the closed mode.
Yes, we can listen to you.
So the component which are involved are nasal. You can see the nasal stent for bilateral that will help in lightly elevate the dome until a reasonable amount of tissue balancing is apparent. Can you see the screen? Is it visible?
You are now unmuted. You are
And
now
then we have
muted.
incorporated 3D screws. These 3D screws are for anterior, posterior, and transverse dimension activation. And then we have acrylic caps which will redistribute the forces uniformly. So this is the case. So 3D screw, how the appliance is placed. So what it does, we want anterior expansion, minimum expansion in posterior, more in the anterior, and move the premaxillary segment into a correct position without doing much of humeroid bending. So this video will show you how it is done. Anterior is in open mode, that will help in the retraction of the premaxilla, and posterior in the closed mode, that will help in the expansion of the alveolar ridge transversely. So this is activation schedule which we give it to the patient. Front screw we activate once in 2 weeks, whereas the back screw we activate twice a week, 2 times in 2 weeks. So what usually happens by giving these screws will stabilize the position of the premaxillary segment and tend to move the premaxillary segment in the same plane without creating much of an extrusion in the premaxillary segment. You can see the amount of changes pre and post treatment. That is how an active appliance in place. You can see the premaxillary segment is now centered and it is in the correct position. To appreciate the amount of changes, I put it all the pictures of the subsequent appointment. So you can see the amount of changes in terms of correction of the premaxilla, centering of premaxilla, and retraction of the premaxillary segment. So you can see pre and post superimposition. And when we did the lateral superimposition, we also found out there is no extrusion of the premaxillary segment. So that was very much favorable. So what we achieved, retraction of the protruded premaxilla, rotated premaxilla assumed to be in median position, approximation of lip segment, significant improvement in the nostril volume, and columella which is not visible previously. You can see there is some amount of columnar lengthening which is occurred. So when you see the cast, you can see appreciate the changes. The anterior posterior length has reduced from 38.5 to 34.5, about 4 mm retraction. Intercanine width anteriorly is increased by 4 mm. By posteriorly, we don't want much of an expansion, so it is increased only by about 2 mm. So this is the second case. You can see the pre-treatment rotated pre-maxilla, same appliance is given. You can see the centering of pre-maxilla, approximation of the cleft defect, and the increase in the columnar length. See pre and post treatment comparison. So the treatment advantages of doing this 3D Versa appliances, it will reduce the number of visits to hospitals, because once we teach the patient how to activate the 3D screw, we don't call the patients very often to the department. So we call them once in 6 weeks only, thus reducing the treatment time and also the burden of care to the patient. So the retraction what we get is very much controlled, and there is minimal omoroid bending. So there is a significant columnar and vestibular lengthening. Simultaneously, anterior constriction and posterior expansion both can be done simultaneously. That is the advantage. The third modification which we have is a mu hook. It's an article which is published in Journal of Contemporary Orthodontics. So usually we get patients, we used to always get a group of patients who couldn't be treated for nasal-alveolar molding. That would be patients with neonatal teeth where plate, you cannot give a plate, ulcerations, with Samonite band, with poor oral hygiene, and so on and so on. So, but those patients were usually not being treated. So we thought, why don't we treat such patients also? And we came up with this modification called as a mu hook. So this is how we get patients with neonatal teeth, ulceration. So making an impression and giving a plate is very difficult, because if you give plate, again the ulceration will increase. This is a patient with Samonite band. So again, in such patients, we don't need to give them a plate. Only nasal molding will be required. So that MU hook would do a lot of things. So how it is made? It is made out of 0.7 millimeter stainless steel wire frame with the bumper sleeve or a wire sleeve which is there. Very simple design. And how it is used with an acrylic bulb, and over the acrylic bulb you use a soft liner. So lip taping is done, and we place the hook diagonally to the opposite side for the nasal molding. So how should the lip tape be done? It is like same how we use for other things. It should be applied from non-cleft side, pulled and put onto the cleft side. So mode of action, it helps the nose to be pulled upward. Lip taping will create the approximate the lip segment closer, thus making nasal as well as alveolar molding possible. So what you need to really take care when you treat such patients, this is one of the complication with mu hook, is that if you exert any force, then there would be overlapping of the greater and lesser segment, creating a T-shaped defect. So I will be talking about it in the complication. So this is the first case. Patient had a very poor oral hygiene with the ulceration. So that's how we have treated pre and post treatment. This is the second case with Semonite band. We needed only nasal molding in this case. So that is how we have treated. This is a bilateral case. Patient had a cardiac problem. So impression taking was contraindicated. That's why we went ahead and did a mu hook modified for bilateral. This is a bilateral case with the rotated premaxilla, and the Semonite band in the palatal side was connected to the buccal side of the thing. So rotating the premaxillary segment was quite a challenge. So we use something called as a differential lip taping in this case along. So how does the differential lip taping done? That is how it is done, and that will rotate the premaxillary segment. So you can see how it is given, and that is the outcome. You can see now the premaxillary segment centered. During surgery, they would cut the Semonite band and reorient the tissues. This is the last case, unilateral, which I was talking about. We have done the lip taping because the patient was coming from a far distance. They couldn't come very often. That's why we decided to give this. But you can see a small overlapping of greater to lesser segment in this case. That is called as a T-shaped defect. So we have tried to do things simple, as Da Vinci quote, simplicity is the ultimate form of sophistication. So before going to the complication, I would say in complications in relation to nasolabial molding, we have categorized into three different categories. One is soft tissue complication, hard tissue complication, and the compliance related problems. So you can see what I was talking about was ulceration. When you have ulcerations, it is very difficult for us to give any appliance with such patient. This ulceration can be due to uneven flanges or poor oral hygiene, or under revived areas or the surface of the molding plate if they are not nicely trimmed and clean and even. So that can also cause ulceration. One more problem is excessive activation. So the pressure on the mucosa, if it is high, then there can be an ulceration. How do we overcome is by giving a mucosal lubrication and softening the roughened surface and trimming of any uh, over contoured or over extension in the flange area. So it is always better to check before sending. You can keep it a little shorter when you see the buccal flanges. So that is how you can correct. You can use the ends of the mouth mirror to check it, because your hands you might find it difficult to put your finger in and check whether visibility is also an issue. So if you have a thin mouth mirror, you can use the other end of mouth mirror to check whether the extension is correct. Bleeding. Irregular or rough surface of the acrylic plate can cause sometimes bleeding. So, so that also need to be corrected by trimming of the surfaces. So in cases where is pressure exerted prolate, we are talking, there are a lot of appliances which will create a severe force on the prolabium. Also, when you use active appliances, if the force is not slow and uniform, sometimes that can lead to hemorrhoid bending or fracture also. That also need to be taken care when you are treating bilateral cases. One more thing is in bilateral, because mm, the nostrils are really small, we might sometimes find it difficult to place the nasal stent. So that time, if your bulb sizes are big, then there might be overstretching of the columella in patients with bilateral cleft. As a result, pressures are exerted on the prolabium tape, and thus there might be ulcerations. Then is tissue or a fungal infection. So if the appliances are not cleaned on a regular basis, if the tapes are not changed on a regular basis, and after removing the plates, if lubrications are not added, So then there can be chances of some fungal infection. So if you see something like that, you need to clean it regularly, prevent any candidal infection which can cause this problem. Fungal infection can be treated using antifungal ointments. Once the infection subsides, you can again continue with the treatment. Then tissue irritation. So irritation of facial epidermis tissue, especially in zygomatic process area. Extraoral surgical tape, what we use, you can always use a base tape to overcome this tissue irritation, and along with some lubrication which need to be done to the skin. Okay, you can see this. This is a common thing which you usually see by doing lip taping. You would see some rashes. Just stop the treatment for a week or so. Once they come back to normal, you can. So you can even use some lotions which can create some lubrication. So that can also overcome these problems. So what all things we need to do? We need to remove the appliance twice daily, clean it nicely. You can use a white paper or a gauze which is available. Clean it thoroughly. Remove all the debris which is there in the plate, and you need to remove the tapes also daily when you take the baby for a bath, and clean it thoroughly. And whenever you are removing the base plate, add some water. You get something called as a micropore tape. This is a paper based tape. So once you add water, it can be removed. So that's how you can overcome any complications which are there. So you see the same patient after 2 weeks. Once you remove the protractor tape, it looks as normal as ever. So other than that, nasal soft tissue complications are there. So nasal septal irritations. So if you overactivate the nasal bulb, there can be something called as a mega nostril, which we don't want. Impingement of nasal epithelium and columnar tearing, which can occur. So there would be like nasal septum irritation in bilateral molding. Usually you get to see, because you need to activate on both the sides. So that you need to be careful. So whenever you activate, check for the blanching, and the blanching should be till it is a little reddish. And if it is more pale, that means you have overactivated, which need to be corrected. So this is what I'm talking about, mega nostril. This is one of the cases where we have done activation was a little more than what is required, created a larger nose. So usually your surgeons will say the nose size would be bigger on the cleft side than on the other side. So we don't need that much of an activation. So that you need to be careful to get the symmetry. And one more problem is stent. Most of the times, once the baby grows up, maybe about a month or 15 days, slowly they will start to push the plate with the tongue. So dislodgement of the plates will be there, along with the stent also can dislodge. So that will be also a problem. Then impingement of nasal epithelium can be seen extremely bruising in the area where the problem is there. Then proper modification of nasal scent is caused by, like, you parents need to monitor these kids on a regular basis, and they should see whether there is proper seating of the appliance is there or not. So that is how we could avoid a lot of other problems. Hard tissue problems, there can be rotation of the lesser segment uh, if the activation is more. Then premature eruption of primary, that we have spoken, that is the neonatal teeth which you usually see. So then there would be a problem. So you see a rotation of a lesser segment, patient with patient with severe nasal deformity, you tend to see this problem. Properly modify and monitor the segment by movement, preventing the rotation. So adequate approximation of the alveolar segment is crucial so that a successful gingivoperioplasty can be done. So some surgeons would say you keep at least a gap of about 2 to 3 millimeter. Don't close the alveolar segment too tightly. So they can do a good gingivoperioplasty. So avoid any T-shaped defect, that is overactivation, and the greater and the lesser segment overlapping each other. So these are the few problems which we usually see. Premature eruption of primary teeth. So if that is there, then molding plate cannot be given. So if erupted teeth is ectopic or supernumerary, extraction is indicated. So if you extract, then you need to discontinue the treatment for some time. Extraction is indicated if the tooth is mobile or interfering with proper activation of the appliance. So, if tooth is erupted in a proper position and orientation, NAM appliance can be modified either by removing acrylic in the area of eruption or not intervening. So that's how it is. NAM modification can be done. You can do your own modification to create a better treatment outcome. So compliance with the complications like NAM therapy is a time consuming therapy. So commitment from the parents is also very much important. Proper placement, retention, hygiene is very critical in this patient. Parents need to be adequately trained. So what we do is we tell them to stay back for 1 or 2 days. Once we feel that they now know how to remove and place their plants, then we send them back home. So till then, at least for a day, we tell them to stay back because most of our patients come from a longer distance. So caretaker parents must approve the treatment by signing and consent, and liquid adhesive enhances the stability. So I don't use because we usually use a passive technique, but there are people who use adhesives for retention. So patient's behavior is also critical, as I said, child becoming more prone to appliance removal by hand or tongue as a neuromuscular this thing has matured, then there is a tendency that they can dislodge the appliance in the oral cavity. So that need to be taken care. So if the child continues to remove the device, then it is no point in continuing with the appliance. So best is to go ahead with the primary lip repair. Or you need to use something like this, an arm restraining device, so that they cannot fold the arm and the appliance can be in position. So this is an article which I came across which says the incidence of soft tissue and hard tissue complications has been estimated about 10%. This is an article in American Cleft journal which was presented in 2007. The compliance issues were of greater concern with an estimated incidence of broken appointments of about 30%, and the estimated incidence of removal of NAM appliance by tongue was about 26. But most of the patients I treat are from an age group of 1 week to 3 weeks. I don't have much problem with an appliance dislodgement with the tongue, but as they grow older, this problem is always there. So, yes, I would like to conclude by saying it is crucial to avoid complications in order to achieve an adequate function and aesthetic result. It is observed that the compliance of the patient and the caregiver or the parent is a key factor in developing successful treatment. So they need to be trained really well for a better treatment outcome. So parents or caregivers must be properly educated and motivated for the treatment. So that is our department in MCOTS. That's Puneet sir, under whom I have been trained. Thank you. Thank you everyone for the patience. Thank you.
That was a wonderful explanation and condensed in a very nice way. Nice to hear you, Dr. Ashith, after long 7 years. I now request Dr. Komal to give vote of thanks.
Good afternoon, everyone. I, Dr. Komal Mankar, Senior Lecturer from Department of Orthodontics, on behalf of entire department, would like to extend my heartfelt gratitude to our esteemed speaker, Dr. Puneet Batra sir and Dr. ASHISH sir, for sparing their valuable time and sparing expertise with us. Thank you so much, sir. I would like to thank Dr. Rashmi Zavlekar ma'am, HOD Department of Orthodontics and Dentofacial Orthopedics, and the entire organizing team and our technical team involved for constantly helping us. Last but not the least, I would like to thank all the participants for their patient listening. Thank you so much.
Thank you, everyone. I now declare the session complete. Tomorrow we will have the second phase of the session starting from 10. Dr. Ashith, I'm presenting you virtually the certificate which I'll post you for your valuable time and presentation. Thank you so much.
Thank you, ma'am. Thank you.
I really wonder. I have worked in for 35 years in the institute with all the staff and
I think you have to upload your slides again, ma'am. You have made you as presenter.
So now can you hear me?
Yes, yes, ma'am. Now it is little bit better.
Okay.
And madam, just move the slides.
Okay. I'll do it. Just tell me if you can see this.
Yes, ma'am. Yes, ma'am. So,
Are they visible? Because I'm unable to see them. Yeah, now it's. Yeah.
slides are visible, ma'am. Only issue is a little bit there is break in the voice.
Okay. Are you able to hear me now?
Yes, ma'am. Yes, yes, ma'am. Yes, ma'am. We'll start. Yes, ma'am. We'll start the session. Good afternoon to you all. I welcome Dr. Deepika Chandak Madam, today's guest speaker, who is a doctor, entrepreneur, an internationally acclaimed active citizen, and also a former faculty member. On the occasion of International Women's Day, she will be speaking on the topic work-life balance for women. So it's honor to have you, madam. Now I request Dr. Niharika Gehlot to introduce today's guest speaker.
I feel extremely privileged and honored to introduce here. Under her leadership as a president in 2021, JCI Nagpur Medico achieved stupendous heights and became Centurion LOM of Zone 9. She has been conferred with numerous national and zone awards, including the Outstanding President of JCI India and Zone 9. She has also received National Award for Outstanding JCI Week of 2021. She has been the outstanding participant of Presidential Academy Speechcraft JTWS Officers Training Seminar, and Mrs. Midcon. Currently, she is Zone Vice President, Zone 9, JCI India, and is also a profound zone trainer. Now I request Dr. Deepika Chandok ma'am to deliver her lecture.
Okay, it's full screen, right?
Or yes, ma'am. You can make it.
Is this visible?
It is visible, ma'am.
Okay, okay. This is fine, right?
Yes, ma'am.
Okay. So this is the first time I'm using this platform. So let's begin. Very good afternoon to all the wonderful staff and students of Swargiya Dadasaheb Karmik Shruti Dental College and Hospital Nagpur. First of all, thank you so much for your kind invitation, and my sincere gratitude to Arun sir and Department of Periodontics for such a wonderful initiative which they've taken today. And before I start, I would just like to share that this is not kind of a where just the speaks and you can just sit and listen. We can have an interactive session. So if you have any queries, if you have any point of views, we would really like to ponder on that and discuss that. Also, Arun, a small request to you: if my voice is not audible in between, please do tell me that. I hope I'm audible, sir.
Yes, ma'am. You are audible.
Okay, perfect. So, dear friends, let's begin with work-life balance for women. So first of all, a very happy Women's Day to all the beautiful, super talented women, and to the amazing men who are listening to me today. Well, when we talk about work-life balance, एक image है जो हमारे दिमाग में आती है कि we say that since time immemorial